Hi, everyone. My name is Andrew Huang, and I'm a palliative care fellow at the University of Rochester Medical Center in Rochester, New York. I have with me Sara Fohl, who is a native of Richmond, Virginia, and a certified hospice and palliative care nurse with the Emily Kirk Cancer Center in Virginia. She's also a mindfulness-based stress reduction registered yoga teacher. In this short video, we're going to talk about hospice. We have a couple objectives to talk a little bit about where hospice came from, what the services it provides, and also when these services are appropriate for a patient. Sara, can you tell us a little bit about what hospice is from your perspective?
Hospice is focusing on quality of life. I was actually first introduced to hospice when my father was in hospice care before I was a nurse. He had prostate cancer. So there does come a point that no matter what we do, that interventions will fail and that we will have to face end of life. Just as there's a specialist that brings us into this life, with pediatricians and gynecologists, it's nice to have folks who know how to guide that process as we leave this life.
Can you talk a little bit about who is the right patient for hospice?
It's not like today's the day. You'll see certain things. For example, with my dad, again, dad was eating less, and caregivers and patients may notice this in their own loved ones and families. They'll be eating less, sleeping more, doing less, needing more help with typical things of life, brushing teeth, bathing, toileting, may have more frequent ED and emergency room visits. So those are all indications that the patient caregivers can see. But as far as coming on to hospice services, I'd like to distinguish between palliative versus hospice care. Now, all hospice care is palliative, but not all palliative care is hospice. And I'd like to make that distinction. Palliative care, again, is not curative in nature. We will have patients come to us in the clinic for palliative treatments to deal with pain, anxiety, perhaps constipation, eating issues that would complement other disciplines. Hospice comes in, however, when we start seeing this trend of not getting better, and it does require a few more things, being a doctor's referral, and it also has to fall under a qualification of a hospice diagnosis, and they fall into some broad categories: cancer, heart failure, neurological disease, most common dementia, Parkinson's, to name a few. Renal disease is another category, so that they would have to qualify. Now, the 6th month, again, cancer patients usually get into hospice later in care and will pass quickly, where neurological patients, on the other hand, and I've taken care of these patients, they may be on hospice services many years because they still qualify. And to qualify, you need to recertify. Again, people can get off a hospice anytime, but the big benefit is that you get a team that is specialized towards your specific needs.
And I think that's such a great way of describing palliative care versus hospice, and that the history of hospice seemed to begin much more with cancer or with heart failure. And only recently have we talked a lot more about neurologic illness. And I think it's a really great point too you mentioned about the multidisciplinary team. Can you talk a little bit about that team?
Oh, I would love to, Andrew. Thank you for asking me, because I think this is one of the best things about hospice care, and I wish all care was like this, because it is patient-centered. Each patient, once accepted onto hospice, will have a medical doctor that is with the hospice organization, but can also have what they call an attending physician, which is a physician of the patient's choosing. Maybe you have a relationship with someone, you'd like to continue that. So that doctor may continue with the care while on hospice. You'll also have a nurse assigned to you who will come out at regular intervals, depending on your needs. A social worker will be made available, not only to help the patient, but to support the family, navigate perhaps emotional, sometimes financial needs. Aides are often available should the caregivers need additional help with bathing and basic care of the patient. Chaplain services are available if needed to guide the non-physical aspects of care. And many hospice agencies also have volunteers that can be available to allow the caregivers to go at maybe have an appointment or take some much needed rest time. But this team works with the patient depending on what their needs are, and those needs may change. And the team can be flexible and change with them.
Hospice can really occur in a lot of different settings. Can you talk a little bit about that as well? Are you commonly seeing hospice patients at home or in other settings?
So there's a variety of options that are available to the patient depending on what their family needs are. You could be in a home. Skilled facilities often an option. Some people prefer a hospital setting. Others have the option, if available, that many hospice organizations may what they call a hospice home or something of the sort that's more of a home environment, maybe not as institutional as a formal hospital, but is not home. So again, there's a number of options that are available depending on what the patient and family needs are. One thing I want to talk about just real briefly and touch base is the cost of hospice. Sometimes people say we can't afford it. Most insurances and Medicare will accept, again, as hospice is fully covered. So that's another point, that there are a lot of benefits, medical equipment, care that you could be receiving at no additional charge because it is available through the hospice agency.
Another question that I've heard a lot is when exactly is the time to transition to hospice from palliative care? Can you shed a little light on that?
Well, again, that is an individual choice, and you need to be qualified. One thing that I would like to impart, and I'd like to quote, I don't know if any of y'all are friends or Mr. Rogers, but Mr. Fred Rogers would have an expression that if it's mentionable, it's manageable. And with those words of wisdom in mind, I encourage people to inquire early, to know what your options are, to have the opportunity to maybe have certain hospice agencies visit to see what might be a good match. Again, there is a qualification and a recertification. Also, say perhaps treatments come up, the patient may revoke hospice and pursue further treatments. So it is very flexible to patients' needs and what's in the best interest of the patient's family and the patient themselves.
Okay. As we close, besides that advice to start early, any other advice you'd have for a care partner or a patient as they consider hospice?
Again, just make those inquiries to see what's good for you. Knowledge is always powerful. It may not be something you want to use, but to have that knowledge, and then when we look into things, maybe they're not so scary, and you and your family can have the full advantage of things that are available to you.